Thank you, sir. Yeah. Good afternoon, ladies and gentlemen. At the outset, heartfelt thanks to the organizers for having me here. So I'll be talking about the AI journey of the Armed Forces Medical Services, what we've achieved and what lies ahead. Sorry. Mhm. Mhm. So a couple of disclosures. I have no conflicts of interest. Army will never allow it. Do know some bit of ATLS, and like all of you, I'm still learning AI. So when we talk about AI, this is the slide everybody showcases. 1950s onwards, the generations have been changing from AI to machine learning to deep learning, and now, I mean, we are all talking about the doomsday. So similarly, our journey started a little late. So it was 6th of July 2023 when the first Chintan Shivir was held. After that, the approvals came in, and finally, with two people, Parikshit Sanyal and Group Captain Rahim, the whole system started. The AFCCM was established. So in less than a year, they've already the focus was it had to function like the data hub for the Armed Forces Medical Services, designing and implementation of AI ML based research projects, and assist AFMS researchers in any big data analysis. With a very basic equipment of a GPU and a couple of computers, these two men started, and they were the pioneers, and the entire journey was is as I'll be showing you in front. They've completed two major projects in the last year: malaria parasite screening from blood smears, followed by AI diagnostic modules for pap smear, blood fluid cytology, and FNAC analysis. There are a lot of projects which are ongoing. So in the ongoing projects, there is an augmented reality microscope for screening of cancer screening and of the cytology smears, again led by Colonel Parikshit. AI-enabled colonic biopsy interpretation. So you'll notice the entire thing is very pathology-centric, so the pathologists in the house can be happy about it. There's prediction of cardiometabolic risk factors, which is in conjunction with the AIIMS Delhi. Then another collaboration with IIT Kanpur, with Colonel Parikshit being at the helm of affairs, detection of acid-fast bacilli in ZN-stained sputum smears. Graphical multi-user client-server based extensible analyzer for big data analysis, again, Parikshit. The initial strides in the AI-based assessment of renal pathology for assessment of renal biopsies. And lastly, the conversion of frozen section images to paraffin section equivalents. So far you've seen it's all path-centric. There's another project going on for screening of retinopathy of prematurity, predicting motor intentions on surface EEG in collaboration with the sports medicine. A lot of MOUs have been signed and buoyed by this basic framework. Now I'm going to come and talk about the work done by the so-called fused pulps. So this is basically the entire bunch of AFMS people who are spread all over the countryside and who've been working with various the available resources they had. So the poster boy in number of patents, Arnab Ghosh. Then at Command Hospital Chandimandir started off the work on development of a AI/ML model for analysis and identification of paranasal sinuses. So this was done by Lieutenant Anubhav Singh and Commander KD Joshi. Then subsequently, another AI/ML model for video laryngoscopy is under development right now. My own journey started off when I was doing my fellowship in advanced robotics. Then the first paper and the natural bent towards machine learning started off. And this was one of the earlier concept papers that I wrote for pre-hospital and trauma life support, how VR can help. We've already had a discussion about it in the morning session. So this was one thing which we've developed. Like quoting General Velu Nair, if your heart is in the right place and you're united by passion, you can develop this thing. We developed in conjunction with Devansh Lalwani. He's a third-year medical student at St. GS Medical College. So can I have the video playing, please? It's primarily for automation. You can turn up the volume. So if required, I can connect my laptop if there isn't. I'll just wait. HDMI directly connects to it either. Yeah. No, you have a HDMI port here. Only HDMI. Epson. Yeah. So this was primarily to automate the surgical data flows in terms of writing of the operative notes.
The case of a 30-year-old male with appendicitis who underwent a standard laparoscopic appendectomy. Operatively, the following findings were there, and the appendix was adherent to the varieties, and there was no evidence of Meckel's, and there was no collection in the right iliac fossa. No major complications were encountered, and hemostasis was good, and standard post-op instructions to be followed.
Just pause it here. At this point, you've just put in, you've finished a case and you've just dictated 3 lines that standard post-op instructions to be followed. What was the intraoperative finding? And the templates are already pre-fit. The system takes on and makes the entire operative note for you, standardized operative note for you.
What is the indication mentioned in the report for Mohan Shah?
And it answers you back as acute appendicitis. So this was, we started off with very basic surgeries like the routine appendicectomies, cholecystectomies, when it comes to scopies, we've just made upper GI endoscopy and standard colonoscopy. We are yet to add on modules. So we are basically adding each and every surgical module and have a huge database, and subsequently just to automate whatever menial tasks and wherever the surgeons are wasting time writing and all, that can be automated, cut shorts the time in the OT. The next project we took on was, again, and this was in collaboration with SMS Medical College. See, normally when we are doing laparoscopies, we always are concerned about the length, what all length of ball, especially when you're doing bariatric surgeries and any anastomosis, you're always concerned about the length from the DJ flexure. How much length have we crossed? What is the exact bowel length? So this was the birth of Surgi measure. So it gives you real-time motion tracking while giving you the exact measurements as to what all, and we've been able to achieve a less than 5% error rate. And the same thing now, we have extended the usage in terms of the training of the surgeons also. Because when you start looking at, now this is a cholecystectomy being done. The surgeon is actually aware as to how much distance is he from the gallbladder and how much is the distance from the CBD that he is working at. So it gives you real-time tracking of this thing. When you're training your residents, one of the things in laparoscopic surgery and robotic surgery is economy of motion. How much is your the movement that you're taking across within the system, which is actually not required. So this also tracks, which helps in the training of the individuals. Now, since morning, we've all been talking about AI. See, what happens is how we look at AI. One algorithm is supposed to take care of everything. You know, that is generally the outlook, that it'll be answer to everything. Whereas actually, yeah, yes. So when we take on this, it's not like a Swiss knife approach that, you know, one size fits all approach will be there. So what happens is it's more like the Lord of the Rings, that for every specific task, there is a separate ring. And that is exactly what we did when we developed this algorithm for the hernia surgery. The next step was what is the commonest surgery done across the globe? And it turned out it's the laparoscopic hernia repairs. So, and the number of things we came up with this hernia decision support system, again done in conjunction with SMS Medical College. So the basic aim is you upload a CT scan, the system reads the CT scan, and you've just fed in the basic information about the BMI, the recurrence status, and the comorbidities. And it takes on to generate a report whereby it gives you the basics of Tanaka index. Even in the next phase, we are trying to have the predictability as to how much tension the closure will be under. And finally, it gives you an entire recommendation list as to that this is the kind of hernia that you're dealing with. Let's say it's an incisional hernia. This is what you're dealing with, and what is the possible recommended surgery in this scenario. The next phase, we are planning to add on the risk analysis part also, that whereby we can take on this. Now, this real-time fluorescence imaging has been around for quite some time in terms of bacterial infection calculations and all. We're just trying to add an AI element to it in terms of, instead of open ulcers, when you have a closed wound, a surgical site infection, can AI help us with real-time and coupled with real-time fluorescence imaging, can we do a surgical site infection surveillance with this? So this project is presently on. The basic concept was the chromophobic nature of the bacteria, whereby the gram-negative were picking up the green color and the positives were picking up the red color. So from all these, it's very clear that slowly but surely we've started our transition from theory to practice. You know, just from laying out the menu card every time we started preparing some of the dishes now. When we talk about the scope ahead, the scope is immense. I mean, you can use either in decision support or in trauma systems. You look at the number of possibilities. We've all been talking about the possibilities since morning. The real-time monitoring, intraoperative support. Radiology as a field has one of the maximum potential whereby you can cut down the manpower, and especially for armed forces where with austere environments, when you don't have enough manpower, you don't have enough radiologists available everywhere, AI will definitely help. This was another device which was initially made just to calculate the intrapartum blood loss. And from there, we've come on to the application to combat trauma. Surgical mentoring, again, this is a surgeon doing a fasciotomy, and the assistant is watching from my point of view angle as to how to do a fasciotomy sitting 50 miles away. Augmented reality, virtual reality, we've all been discussing quite a lot. The basic advantage with this is that it actually gives you the exact anatomical structures and the planes as you proceed ahead in a surgery. So out here, and you can see this is a surgeon being trained and to an ortho surgeon basically how to position the limb in order to do the incision for a joint replacement. Now, so far, we've talked about the good stuff. Yes, there are certain challenges when it comes to implementation of AI, especially from the armed forces perspective. The major challenge is real-time data connectivity. Majority of the algorithms so far need a real-time data connectivity. We are slowly and surely progressing towards this, whereby we have a lot of people, a lot of innovators coming in with softwares which do not require a real-time data connectivity and can learn on their own. But real-life applications will take some time. The remote locations, data security, ethical and medical legal concerns do remain. Now, AI per se has its own set of limitations. I mean, as seen in this picture, the entire time, the entire football game, the camera was only tracking the referee's head. To a more sinister complication whereby the chatbot tells a teen to kill her parents. So the common limitations that we encounter are hallucinations. When you make it's a trade-off. When you try and make the algorithm very predictive, it starts hallucinating. It starts over-targeting things. There is an obvious lack of reasoning and explainability. There's lack of emotional intelligence. We've already talked about it in detail in the previous session. Algorithmic and data biases will remain because as of now, the whatever is fed is actually somewhere fed by a human. So it all depends upon the person who was feeding. One of the famous examples of this is when Google Photos initially started off, it would pick up anybody with a dark skin tone and label them as a gorilla. So after a lot of hue and cry, this entire feature was taken away from Google Photos, and then subsequently they've corrected the algorithm. This is one of those few examples. Quality and relevant data, yes. Majority of the models right now are actually working on simulated data. You feed in the data, it achieves a basic threshold, and after that you let the system keep learning itself based on the simulations it carries out. Whether it's something like I am thinking of something in my own mind and I'm repeatedly thinking about it and then creating a bias towards it. Whereas the actual need is the bias, for the bias to go away, is actual authentic data to come in. There are a lot of unforeseen outcomes that come with these things we have not catered for. One of the examples was in the previous session. So in the other part, now this was an algorithm for the retinopathy. It is supposed to analyze for retinopathy. What it does is it's continuously reanalyzing the similar pictures. The noise starts creeping in. And after a couple of cycles, it starts reading a normal image as a diabetic retinopathy. On the bright side, yes, particularly from the armed forces medical services perspective, yes, technology can make up for the manpower deficiency. A lot of times we struggle with the early decision making. So once we have the resources in place, this will help in conservation of the resources, especially when it comes to taking decisions like air evacs and management of trauma cases, the kind of resources we need. Increasing number of Indian startups will obviously reduce our offshore data security concerns. Ladies and gentlemen, AI is here to stay, and we all need to embrace it. And I'm going to leave you with these words from Henry Ford. If I'd asked people what they wanted, they would have asked for faster horses. So it's time we need to gear up. AI is here. Thank you.
Thank you, Aman, for such a wonderful talk.